Hello and welcome back. Let's go through the pharmacokinetics. So, metabolism. First step is disintegration. So that takes time. Disintegration is basically you taking a tablet, the stomach has to grind it up. Dissolution is when the drug is in a solution, and that means like stomach acid. It's now available for absorption either through the gastric walls or in the intestines. So from there, it goes into the it goes into the blood, as a free drug, and then the drug is bound to a protein, usually albumin, and it's metabolized in by transformation, excreted, and the useful thing to take away is that solutions and syrups will bypass the disintegration and the dissolution process, of course, because it's already in a solution. So the superfamily of ATP binding cassette proteins are going to be your P glycoproteins, and that causes the efflux of whatever the drug needs to do. So it could be an efflux of calcium, it could be an efflux of sodium, whatever. Verapamil is going to inhibit it to increase the efficacy of the drug, so we don't want to release the drug. We want to bind the drug. Efflux will release the drug as a free drug. Solute carriers are going to be symports, co-transports, and antiports. We should all know that. Tricyclic antidepressants will decrease sodium and chloride-dependent norepinephrine, and serotonin reuptake will decrease. And there is going to be like a conformational change, of course, and that's how like active sites, allosteric sites, that's going to cause all of that. Remember all of this. So remember that for IV, it's going to be 100% bioavailability. So F is equal to 1, and F is just bioavailability. It's going to be less than 100% for all other routes. It's due to like incomplete absorption, first pass metabolism, local binding, etc. And the biologically inequivalent is subtracted from the different, that's going to be the difference of bioavailability between different drugs, right? So a bioequivalent is going to be the similar bioavailability for both drugs. Difference has to be a little bit less than 20%. And chemically equivalent is basically the same strength or dose. The bioavailability is going to depend on the maximum plasma drug concentration, of course, and the time needed to reach Cmax. The area under the curve is going to be the concentration in the plasma, and the bioavailability after the oral route is basically the AUC divided by AUC of the IV times 100%, so oral divided by IV. So its distribution is going to be affected by the solubility of the compound, whether it is ionized or not, and whether it's bound, along with blood flow. So like I said, remember in shock, medication, even in intramuscular or subcutaneous route, is going to be decreased, is because of the slower blood flow. Volume distribution is going to be the fluid volume, where the drug appears to be distributed in a concentration similar to plasma. So it's basically like when the drug is going to be equal to like a normal concentration in plasma. And factors influencing it are the properties of the drug, along with other factors depending on the patient. So whether they have congestive heart failure, cirrhosis, and renal disease, that affects metabolism. And they all determine whether a loading dose is needed or if dialysis would be helpful in an overdose. So plasma protein binding usually is just to albumin, while basic drugs will bind to an alpha-1 acid glycoprotein, also known as orosomucoid. And like I said, a plasma drug is inactive, and higher plasma protein-bound drugs will have a low VD and a longer duration of action because since they're bound, it's going to take a while for them to be metabolized and be freed, right? So in hypoalbuminemia, the free drug concentration will increase because there's no albumin to bind. Aspirin, along with sulfonylurea, they contraindicate each other and increase the hypoglycemia because the aspirin will free too much of the sulfonylurea. Indomethacin or phenytoin, along with warfarin, they interact, increase bleeding. Sulfonamides in neonates will increase the risk of kernicterus because it's not really of any interaction, but the liver in babies are not quite mature, and unconjugated bilirubins will be present, and this will increase the amount of unconjugated bilirubin. So drugs can be stored, and depending on the drug, digoxin is going to be stored in the heart. Chloroquine, this is an anti-malarial drug. I think it's also an anti-epileptic drug. Is going to be stored in the liver and the retina. Iodine, of course, in the thyroid. Chlorpromazine is going to be stored in the brain, and tetracycline in the bone and the teeth. And there is going to be a certain area in the brain called the area postrema. That is the only area in the brain where the blood-brain barrier is absent. It's also the vomiting center. Redistribution, so after IV or inhalation, the very lipid-soluble drugs will go straight to the organs with high blood flow first, and then the less vascular and bulky tissue. And that shortens the effects of some drugs because it's instantly stored. Biotransformation is when things are converted and makes active metabolites from active drugs, but in some they will inactivate some drugs and activate some drugs. The non-synthetic or phase 1 reaction is when the metabolites will be active or inactive, and the synthetic or phase 2 reaction is when most of the metabolites are just inactive. And then, of course, they have to be conjugated. So, phase 1 is oxidation, and it requires cytochrome P450 and NADPH and the cytochrome reductase along with oxygen, of course, because it's being oxidized. The most important versions of P450 is CYP34A and CYP3 3A5. So the additions of oxygen or negatively charged radical and or the removal of hydrogen or positively charged radical, that all leads to hydroxylation, oxygenation, dealkylation, and oxidation deamination. What's all this important to know? This is all being oxidized, and the drug is being conjugated. So this is pretty important. Remember that cytochrome P450 is mainly the main player in drug metabolism, and they have a role in using iron and transforming the ferrous to the ferric compound, and it produces water along with the oxidized drug product. And the hydrolysis is going to be producing acid and its conjugate base. So amidases and esterases are non-microsomal, so it's not producing the mitochondria, non-inducible, and they're affected by genetic polymorphisms. These are found in the liver, the plasma, and the gastric mucosa. Phase 2 is when the liver conjugates things. Enzymes and endogenous substances are involved. UDP are inducible, so without it, the UGT1A1, this is a receptor deficiency, is going to lead to the Gilbert and Crigler-Najjar syndrome. And the loss of function of this receptor is going to increase the irinotecan, induce bone marrow depression and diarrhea. So phenobarbital can be used to treat the Crigler-Najjar syndrome, only type 2 though. And chloramphenicol, once it's conjugated, it's toxic to babies. So you can add functional groups by acetylation, and it's going to be affected by the genetic polymorphism. Isoniazides and sulfonamides are really affected by this. People with problems with glutathione conjugation, they are prone to acetaminophen toxicity. And acetylcysteine is going to be given for the toxicity to detox the quinone or the epoxide metabolites formed. Other functional groups could be methyl, it can be sulfur, it can be glycines. So microsomal is going to be present in the smooth endoplasmic reticulum. Just blank there. They're inducible, and they're all these. The non-microsomal, remember esterase, amidases, those are the most important ones. Those are non-inducible. Enzyme induction is going to increase the synthesis, and it's going to make the metabolism faster, decreased effect because you're excreting faster. Enzyme inhibition is going to decrease the synthesis, slower metabolism, increase the effect. So it stays in the system longer. So CYP3A45, it's going to metabolize 50% of the phase 1 path. So this is going to be important in the oxidation. UGT is going to metabolize 25% of the phase 2 path. So this is going to be important in the conjugation. UGT is the one subject to the polymorphism. Okay, so all of these are the enzyme inducers. The most important ones to remember is the St. John's worts and smoking and ethanol usage. This is an interesting little mnemonic. So grapefruit juice will encode with Coke very much. This is Coke. I'm not sure why it's just grapefruit juice, but I think it's because of the high acidity, but you'd think that orange juice would also interact, but it's grapefruit juice, just remember that. So inducers will decrease the efficacy of the drug, and the inhibitors will make it too effective, which will lead to the toxicity of the drug. Why is that, right? So enzyme inducers, and they will increase the metabolism of the body. That's why it makes it less effective. Inhibitor prevents the breakdown. Too much is left in the body. Excretion is usually urine. Only a few only a few other drugs are excreted through different routes. Milk is going to be breast milk in females, and these are the drugs that can be passed to children. So glomerular filtration is going to be the fastest in the renal excretion process. In the tubular reabsorption process, the unionized drugs are going to be reabsorbed, while in tubular secretion, the meds are going to be ionized and secreted. So we want them to be ionized and secreted. So bound drugs are neither filtered nor secreted, so those are going to just stay in the system. And how do we increase the excretion? So we acidify the urine, or we alkalinize the urine. The notable exception is aspirin. So in aspirin overdose, it causes metabolic acidosis and a urinary alkalinization. So it's going to increase excretion. Half-life, of course, is going to be how long it takes for half-life of the drugs to be metabolized. For first order is important. It's usually 4 to 5 half-lives required for 95% of the elimination. The rate of elimination is constant of first order kinetics, and the clearance increases with higher doses, so it's the rate that's important. Zero kinetics is when the metabolism is saturable, so it's going to be dependent on concentration, and the same amount of the drug is eliminated per time. So that's not good, because in a first order elimination is the same proportion of the drug. It gives you a lot more leeway. So a person taking a first order elimination kind of drug is not going to be at higher risk for toxicity. So just look at this example. 2% of the available drug is eliminated per minute, while 2 is going to be eliminated regardless. So this is amount, this is percentage. So a steady state concentration is how much of the drugs need to be effective. And like I said, first order kinetics, half-life determines how many doses are needed. And moving on. So loading dose is needed only if the drug takes a very long time to work or has a very long half-life. And you want to achieve the steady state quickly. So if you're in the hospital, you don't want to take 3-4 days for things to work. You want to saturate the proteins, and then you maintain. But once again, maintenance dose depends on the excretion and metabolizing organs. So these are just going to be the formulas that you should know. Loading dose, how much you should start with. Dosing rate, how much is going to be cleared and how much is going to be available. And volume distribution, how much of the drug is in the plasma itself. Corrected dose, it's going to depend on, of course, this is going to depend on the kidneys, so creatinine clearance. If 100% is cleared by the kidney, there is no need for the corrected dose. Infusion rate, of course, maintenance dose, depends on dosing interval, clearance, and the bioavailability. And you want a low binding protein low affinity binding protein, because when it's bound, it stays in the system for too long and could lead to toxicity. Okay, so that's it for now. Thank you for your attention, and good luck studying.